will have like
All right, let's go ahead and get started. Today is probably the most interesting lecture we'll have. Believe it or not, my lecture on sodium potassium exchange pump was not as exciting as this today, I think. But anyway, so today we got Dr. Chris Porterfield. He's a local electrophysiologist here in San Luis Obispo at Coastal Cardiology, and really fascinating and lots of good background. So, Chris, I'm just going to turn it over to you. Thank you.
Sounds good. My name is Chris. I've met a few of you already, and hopefully I'll meet the rest of you at some point. As Jamie's or Dr. Easton said, I am a cardiac electrophysiologist. If you don't know what that means, it's probably for the best. Please stop, ask questions. I really like dynamic interaction, very low key. We'll try to go through the cardiac arrhythmias. Some of this will make sense, some of it won't. Some of it might make sense the second or third time you hear it from me. I invite all of you to come to my lab and watch these procedures go on, because it's a lot more interesting to actually see what we're doing than watching me talk about this stuff. So you all know that the cardiac cells have specialized cells that contribute to the electrical conduction. So you have the sinoatrial cells, the AV nodal cells, the bundle of His Purkinje fibers with the bundle branches just prior to that. Here's a picture of the conduction system. So the sinoatrial cells generate, those are the natural pacemaker cells, somewhere between 50 and 100, depends on who you are. If you're really avid athlete, that can be a little lower, but those cells generate your actual heartbeat. That travels down through the atrium, through the AV node, the His bundle here, then the right and left bundle branches, and the Purkinje networks. We'll discuss that in a little bit more detail. The EKG, that's our way of visualizing the electrical conduction to the heart. So P wave, that's what starts the sinoatrial cells. So when you see a P wave on the EKG, you know, okay, well, that's when the heartbeat's starting. It goes through to the AV node. So I have a picture next that shows this, but this is all AV nodal conduction, bundle of His through the AV node, all the way through the bundle branches, and then repolarization to the T wave. So the QT interval, PR interval, SE segment, and QRS segments are very important for us as electrophysiologists. So this is another way of looking at it. So this is really nice because it's color coordinated, and you can tell, that's supraventricular. So the atrial cells, this is ventricular, and then repolarization of the ventricular muscle. So like we already said, heart rates vary greatly. We could check all of our heart rates and compare how they're going. I did that to one class, and one girl was 120. I was like, maybe we won't do this anymore. When we sleep, our heart rate's always the lowest. Athletes, and by athletes, people who are very avid runners, can have pauses in the middle of the night. Their vagal tone is really high, and they tend to actually develop atrial fibrillation early on. So I do not advise that people run marathons. Profound bradycardia during sleep with people with sleep apnea. So if you're really morbidly obese and stop breathing, then your heart often stops as well. Your heart rate over 100 is termed tachycardia or fast rhythm. So we always think of, if it's going extremely fast, like I just saw a kid this morning at 8:30 this morning that had a heart rate of 240 beats a minute. That was a little fast. He's got a pathway. Wolf Parkinson White, we'll talk about that in a second, but that's a very common diagnosis, and that's something I can make very quickly. So the action potential, I know you guys talked about this already, but this part used to drive me nuts. I used to memorize this for the exam. So I'll put that on there for you. But so extracellular, intracellular, 4, and then 0 through 3. So sodium going into the cell for phase 0, potassium leaving, calcium and potassium exchanging, and then potassium inward current for phase 3. all the phases are very important. And for me, I'm also a geneticist, so I deal with a lot of genetic disorders. And a lot of what I've looked at in the phase 1 through phase 3 are genetic disorders in patients with prolonged QT interval and certain disorders of the myocytes. So arrhythmia mechanisms, there are 3. Reentry, that's the most common. So reentry is just something that's going around in a circuit. Enhanced automaticity, it's abnormal responses to impulse formation from the myocytes. And then triggered activity, you can have early or delayed. Most of these are like with electrolyte abnormalities or drugs. So with reentry, you get, the most common is bidirectional conduction. So it can go both ways. So it's going around the circuit one way or the other way. It can go both, and all you need is an extra beat to set off the circuit. Unidirectional block is it can only go in one direction in this circuit. And so there are a couple of arrhythmias that we'll be talking about that have unidirectional block. Then there's recovery and excitability with reentry. And so there's an area of slow conduction and faster or normal conduction, and it has kind of a tail or lag response. We'll kind of briefly talk about that. It's not as interesting as I make it sound. So in the atrium, this is a type of reentry where you have fast conduction or normal conduction, noted the fast pathway, and then the slow pathway. So if the fast pathway is already active, then conduction can go down the slow pathway, and it sets up a loop of circuit. And so it's just like any simple physics or electrical properties of any tissue. So if something's available, it's going to take the least resistance until it's blocked, and then it will take the other circuit, and it just sets up a loop. This is really boring. So with triggered activity, so you get early and late after depolarizations. These are interesting to us because the early and late they cause different things. So in delayed or late after depolarizations, commonly caused by digoxin, or digitalis, which is the medication that we use to slow atrial fibrillation in most patients. If you get too much digoxin or digitoxic, you can have delayed after depolarizations causing torsade, which equals death. So it's important, we can actually see some subtle hints of that on patients' EKGs. You can actually do intramyocyte potentials. We don't do those anymore, but it's basically like sticking a needle in a myocyte in the heart and looking at what is going on with the electrical activity.
One quick question.
Yeah.
So when you give digoxin, what kind of currents does that affect?
Mostly calcium.
You guys know about that? Let's keep them awake.
Yeah. Remember that, I guess.
All we've talked about is details about currents.
Oh, yeah, all the currents.
Yeah.
So these are the drugs and issues that can cause delayed or early after depolarizations. You don't need to remember all these. The most common that we see are either hypo or hyperkalemia. So high or low potassium tend to be the most problematic for us. So the reentry. So reentry, you have that kind of tail and the head of the circuit. So the wavefront starts, comes around, there's a leading circuit. It's all about, if you think about cells and electrical wavefronts, it's some of the cells are depolarizing while the others are recovering. And so they're kind of setting up this round circuit. And what we're trying to find as electrophysiologists is where's the start, where's the finish, is it a full circuit, and where can we ablate or get rid of to stop this from occurring? So we classify the arrhythmias. Mostly we talk about the tachyarrhythmias, but we also discuss bradyarrhythmias. So bradyarrhythmias, too slow, often require pacemaker implantation. Tachyarrhythmias is what we'll spend most of the time talking about. For the tachyarrhythmias, we divide them into, are they happening in the upper chambers of the heart or the atria, which is supraventricular, or in the ventricles, which are below the atria. So in the supraventricular arrhythmias, you have focal atrial tachycardia. We break those into right and left atrial, so the rats and the lats. The right atrial tachycardias are by and far more common. Atrial flutter, it's either typical or atypical. We'll talk about those. AV-NRT, that's the most common reentrant SVT. There's someone in this room that has that, I'm sure. You just don't know it yet. AVRT, atrioventricular reentrant tachycardia. That's in the pre-excited categories. It has extra pathway. And so Wolf, Parkinson, White. Anybody ever been diagnosed with WPW in here? Oh, good. Atrial fibrillation, junctional tachycardia, and then sinus tachycardia. That's a fast heart rate coming from the sinus node. It can be appropriate or inappropriate. If you're running from a bear, it's appropriate. If you're just sitting in class and it's going really fast, it's inappropriate. Ventricular arrhythmias, ventricular tachycardia can be monomorphic, meaning that the electrical force is symmetric throughout the rhythm. Polymorphic, often caused by ischemia, heart attack, drugs, or genetic issues. Bundle branch reentry is just a sick ventricle. And then ventricular fibrillation, which equals death. So these are the supraventricular tachycardia. So we talked about all of these. So you can have sinus node reentry. That's just a reentrant circuit around the sinus node. You can develop atrial flutter. This is typical atrial flutter. It can go counterclockwise or clockwise around the tricuspid valve. Atypical flutter is on the left side. AV-NRT is coming down the slow pathway and back up the fast pathway. So you're going around the AV node. You're actually born with two distinct AV nodal pathways. 20% of us have that. So 20% of us have dual AV nodal physiology. And of the 20% of us in this room that have dual AV nodal physiology, only 5% of that group will actually develop the tachycardia. They think that it's actually increasing to closer to 10% now because of Starbucks or something, but we're seeing an actual increase in AV node reentry. You can get junctional tachycardia, which is a focal tachycardia coming from the junction. You can get AVRT, which is a bypass tract. So this is an area that, unlike the AV node, it's separated and it allows for one-to-one atrial to ventricular conduction or ventricular to atrial conduction. So it's a direct path from the atrium to the ventricle, which is dangerous. The AV node has properties in which it allows a kind of slow conduction. So the AV node says, I'm going to allow a certain rate to go through, but if it goes above 200, we say 220 minus your age. So if it is above that rate, then it won't allow that. So it's kind of like a governor on your heart to help protect you from really bad things. But if you have a bypass tract, all bets are off. So as an electrophysiologist, we divide these into different RP intervals. That sounds really boring too, but so the RP interval is this is the R wave, this is the P wave. And so when we're looking at an EKG, at tracing, I can tell you, hey, I think this is this type of arrhythmia. This is why, and this is because understanding what type of arrhythmia it is very important to diagnosing, treating, and potentially ablating. So the short RP interval is typically AV-NRT and possibly AVRT. Long RP, atrial tachycardia, atypical AV-NRT, PJRT, and sinus tachycardia. And then if you don't see a P wave, it's almost always typical AV node reentry in narrow complex tachycardia. So the FATs or RATs or LATs, focal atrial tachycardia is typically we see this in older patients with larger atrium. Typically 80% come from the right atrium, 20% from the left atrium. If it's in the right atrium, the crista and the right atrium are the most common spots. We see this as kind of like a precursor to atrial fibrillation. So these are extra beats. It's typically thought of as a focal firing in the atrium. So cells that are firing at a rate faster than the sinus node. So the sinus node is asleep or dormant during this. So you're getting firing at 120, 180, somewhere between there. And this is suppressing the sinus node. And so we can give medications. That's what we typically would try, typically beta blockers or calcium channel blockers to suppress it. Then using some of the sodium channel blockers, which are class 1C antiarrhythmics, those drugs like flecainide and propafenone help to really suppress atrial arrhythmias. So this is an example of an atrial tachycardia. So you can see that down here, there should be only one P wave, and the P wave should be, closer to the QRS, but you see this kind of thing marching through without any real relationship to the QRS. I put arrows over here for you to see them easier, but that's an atrial tachycardia that's growing quite fast. It looks like it's a right posterior septal atrial tachycardia based on the vector. So with vectors, we look at the EKG, and I can tell you kind of where this is coming from. And we're about 30% accurate, but when we say that, so it's more of a guess, but we're at least usually somewhere in the general area. So this is another example of atrial tachycardia. We gave adenosine. So adenosine causes transient AV block. If you've never had adenosine, it feels like you're about to die when they push it. I've never had it, but my patients always say, I feel like I'm dying. Your heart stops for about 3 seconds, and you really feel bad. But it does stop, the arrhythmia sometimes. In this case, you have the tachycardia. So these are the ventricular beats, the R waves. You can see there's a 1-to-1 tachycardia. It then starts spacing out, and you get block of the AV node, so the atrial beats march through. So this is an atrial tachycardia. It persists, so if it was like WPW or AV node reentry, it would terminate because you take out the AV node, that's part of the circuit. But we suppress the AV node, and it keeps going. So this is an atrial tachycardia, a tachycardia that's only from the atrium, not taking part through the AV node. Atrial flutter, typical versus atypical. It's a pretty common arrhythmia in older people. The majority are from the right atrium, unless they've had history of surgery, have significant mitral valve disease, had a high risk of ablation or history of ablation, or have had surgery in the past. There is a slight risk of stroke. There's actually a slight risk of ventricular fibrillation or sudden death in flutter, but it's pretty rare. We typically will ablate. I'll show that towards the end. I have another program on my surface that I'll show. So this is flutter. It looks similar to atrial tachycardia, but you'll see these little flutter waves. And so somebody said that it looked like a sawtooth, but we don't use sawtooth like saws, like the teeth of saws. We don't use those anymore, so, or at least I don't. So I didn't know what that was. But that's, so if it's negative in 2, 3, and AVF, that's the inferior lead. So that's coming down, around, and up the septum in the right atrium. And it's positive in V1. So that's a right-sided typical atrial flutter. So I can ablate this very easily by going up through the leg, going up into the right atrium, and ablating a small 1.5 centimeters of tissue behind the tricuspid valve. AV NRT typically starts in the youth. This is the dual AV nodal physiology that I was telling you 20% of us have. Typically will terminate with vagal maneuvers. So one thing, if any of you ever develop a fast heart rate and it feels like your chest is beating out of your, or your heart's beating out of your chest, just bear down like you're doing crunches, hold it for about 3 to 5 seconds, and that typically will terminate the rhythm early on. It's less effective as we get older. So very short RP interval. We look for that kind of, I'll show you in a second, this pseudo R wave or R prime in V1. It's the most common reentrant SVT, which we spoke about. Your rate may actually go above, your pulse may actually go above 200 with this rhythm, but typically less than 210. So this is just a, so this is the initiation. You have to have an extra beat for this to occur because you have to have predominant forces going down the fast pathway. That has to be taken up, that the cells in the fast pathway have to be busy so that an extra beat can come up through the slow pathway, and then the fast pathway has recovered so that the electrical forces now can travel back up the fast pathway and then start the reentrant circuit. That's typical AV node reentry. And so we, when we ablate these, we ablate the slow pathway. We take out the slow pathway. If you ablate the fast pathway, then you're just left with the slow pathway, then you get a pacemaker. This is a better EKG. You can see the little tiny it's hard to see on this, but there's a little tiny pseudo R prime in V1. Very classic looking AV node reentry. Here's another one. Also this little hump, very short RP interval. That's AV in RT. So pre-excitation or AV-RT, this is accessory pathways. This is something you're born with. We typically have been starting to screen infants as they're born with just a quick EKG since 2013, but there are a few that slip through the cracks. And typically, if this will show up on a EKG at birth, if it doesn't go away by age 5, then you will start to have problems. And some patients can die suddenly because their heart rate goes to 250, 300, 400 beats a minute. Anything above 350, 400, your risk of sudden death greatly increases. We almost always ablate these. I just did an ablation on Tuesday on a young 8-year-old with WPW. She was able to conduct to 340 beats a minute. So with AV-RT, it can be orthodromic, which is the most common. Antidromic, I think of anti, bad. Bad means that it's a wide complex rhythm because it's going through the pathway and backwards through the AV node. The majority of these go, the circuit actually goes through the AV node and backwards through the pathway. The importance of the orthodromic is that these can be treated with AV nodal blockers like beta blockers and calcium channel blockers, or you can give adenosine and it's much more effective. If you block the AV node in these, the majority of these will stop. And so the biggest problem is when you develop atrial fibrillation, which has, the AFib, the atrial rate is around 500 to 600 beats a minute. And if you have a pathway, then all of those beats are going to go through to your ventricle. That's when people will die. And that's the biggest problem with this. So when we look at an EKG with WPW, you see this kind of weird notch. It's like a slurred upstroke. That's called a delta wave, and that signifies that these patients have a bypass tract, something that's getting to the ventricle. So there's an electrical signal getting to the ventricle quicker than to the AV node. And so it's beating it or pre-exciting the ventricle. That's why it gets the same. So just more examples of WPW. So this is you see a negative in AVR, so that's the right free wall pathway. This one was negative in AVL, more negative in AVL, and it's left lateral. This is the free wall. This is just a cartoon of where the pathways come from. So this is the tricuspid valve, mitral valve. This is the coronary sinus, which is the main vein of the heart, the AV node, the His bundle. So it's either the right free wall, the left free wall, or left lateral. This is the most common, 80%. Then the rest are in the septal region, so anterior, mid, or posterior septum. You get nervous if it's mid or anterior septal because you can, if you ablate it, you can take out the AV node. Then they need a pacemaker. That's not fun. So this is what WPW looks like in atrial fibrillation. So really fast, bizarre EKG, but you see pre-excitation. You see that delta wave even when they're going fast. So that means that there's this patient had a left lateral pathway. Atrial fibrillation. So this is by and far the most common arrhythmia that we see. It's the arrhythmia of aging. So 90% of us will have it by the age of 90. So you'll probably have it a little bit more frequently than runners, bikers, all the Tour de France guys get it early. They're intense trainers, so their atrium increase and enlarge, and they all get AFib. It's typically paroxysmal, so it comes and goes, but develops into persistent AFib. And with persistent AFib, that causes a lot more problems, including decreased cardiac output. You get electrical and structural remodeling, causes the left atrium to enlarge, and they get conduction abnormalities, which cause pauses and need for a pacemaker. About 50% of people with AFib need pacemakers. We will commonly ablate these patients early on or use antiarrhythmic drugs. The class 3 antiarrhythmics, so sotalol, Tecousin, amiodarone, Multac. Those are the drugs that we really like to use in atrial fibrillation. So this is what atrial fibrillation looks like. It's commonly expressed as being irregular, so very irregular conduction. You can see maybe a little bit of atrial activity, but the atrial activity is hard to discern on EKGs with atrial fibrillation. That's common because you've got multiple drivers and focal lesions in atrial fibrillation that are causing the atrium to fibrillate around 400 to 600 beats a minute. I'll show you at the end atrial fibrillation. This is just a summary slide of the arrhythmias for when you can't sleep one night, you can read it. Ventricular tachycardia. So we're going down to the ventricles, so the lower chambers of the heart. So when we talk about ventricular arrhythmias, they're basically two. There's ventricular tachycardia and then there's ventricular fibrillation. There are a lot of other nuances to them, but that's, to keep it simple, ventricular tachycardia, that's a rhythm that typically occurs in either structurally normal or abnormal hearts. So in structurally normal hearts, it's people that have either exercise-induced ventricular tachycardia. You can get outflow tract tachycardia, and these are more cellular issues, so cellular changes that cause the ventricular tachycardia to occur. There's often a scar in, I have a patient that I had on the treadmill last night around 4:30, and she was running and she developed palpitations and she suddenly went into ventricular tachycardia, peak exercise. And what we think is that her pulmonic valve was growing so fast when she was running because her heart rate was growing so fast that pulmonic valve is slapping against the myocytes and actually can cause you to develop scar and go into ventricular tachycardia. We treat them the same. We either go in and ablate it or give them drugs. We describe this as monomorphic or polymorphic. I'll show you what those look like in a second. Polymorphic is also described as torsade de pont. It's a French term that I can't say very well. Torsade typically occurs because of prolonged QT intervals. And you remember that QT interval is repolarization of the ventricles. So as the ventricles are relaxing, there's an abnormality in the cellular chemistry. So this is monomorphic VT. So all of these QRS complexes look the same. That's monomorphic. So it has the same structure. This is upright in 2, 3, and ABF. So that's coming out from high up in the heart, so outflow tract. And it's upright all the way from B1 all the way to B6. So it's likely in the septal, anterior septal RVOT. One of the things that you look for when you're in VT, it's a wider complex rhythm. So it's not as narrow, although this is a fairly narrow VT. You also look for VA dissociation. So B, you should not have a B and an A. VA, it's actually VVVA, VVA. So the A and the V's don't correlate. This is a purely ventricular rhythm. It has no conduction through the AV node. So it's not a one-to-one V to A or A to V relationship. Does everybody understand that? Hopefully. Non-sustained ventricular tachycardia. So this is just clusters of VT. So 3 beats here, 3 beats here. That's a PVC, a double, so or couplet. So this is commonly what we see in patients with some type of scar, history of MI, an area that's irritable in the ventricle. So I have a quick case on a 25-year-old that is a patient of mine. He went to his primary care physician complaining of palpitations. He was putting a horseshoe on a horse and became very short of breath, lightheaded. He actually passed out, but couldn't remember if he passed out or just fell over, but he did pass out. He passed out a few other times en route to his primary care physician's office. His heart rate was 220 beats a minute when he arrived to the emergency room. In the emergency room, he was given adenosine, which did not work, then digoxin, and then amiodarone. None of these actually terminated the rhythm, and he was placed on esmolol, which is an IV beta blocker, and then given IV diltiazem, which is another calcium channel blocker. and then he finally terminated to sinus rhythm. This was his EKG. So quite fast. It's an interesting EKG because it's fractionated, meaning that there's these double potentials here and here, and then it's negative in 2, 3, and AVF, so it's lower down in the heart and the ventricle, and it's upright in V1 and V2, meaning that's probably leftward instead of rightward. These are intracardiac echocardiograms, so this is what we look at when we're in the EP lab, when we have catheters in the heart. So we have catheters that are in the right atrium. So this is the right atrium. This is the coronary sinus, which is the main vein of the heart. This is the His. The His is this is the A His bundle, and then the along the bundle branch or ventricular myocytes. And then this is the ventricular signal. So we're looking at from atrial to ventricular. We induced ventricular tachycardia. So this is very similar to what he had. You see that kind of funny looking, we call them bunny ears, or fractionated electrograms, upright in V1, transitioning late in the precordium, and negative in 2, 3, and AVF, like we had discussed. So we, when we're in there, we like to pace, and we like to electrically stimulate the ventricular myocytes. So we put in a wavefront of electrical current. You can kind of think of the ventricular, when you have ventricular tachycardia, there's a circuit, and we're putting in a wavefront of energy, and we're trying to either blend into the circuit. So if we're sending in a slightly faster current, it's going to go in and actually beat out the current rhythm. And then you stop pacing, and you see how long it takes to get from that point back to your catheter. And so we do all these pacing maneuvers to try to tell us how far away we are. So the closer you get to the circuit, if you're actually in the circuit, that cycle back to you should be the exact tachycardia cycle length that the patient is in. And so we measure that. We do that a number of times while we're in there, and we can actually map out the circuit and find, where's the entry part, where's the exit, and a lot of other nuances that you don't really want to hear about. But so this is still, we gave adenosine just to prove. So you see block. So here's A, but your V's are still going through. We gave adenosine just to look at the effect on the ventricular tachycardia. We paced from the right ventricle, you get a long circuit. So this is coming from the left side. We reinitiated ventricular tachycardia and confirmed. This was not on the right ventricular septum, so we went to the left side. And this is the left ventricle. This is a map that we use. So this is the left ventricle. And so we map out where this is the His bundle. This is a papillary muscle. And so this papillary muscle, it holds these chordae that attach to your mitral valve. And this was where this was coming from. This is a papillary muscle ventricular tachycardia, which is common in younger people. And we ablated in this region, and it stopped. And he's done very well for the last 2 years without any recurrence. One of the other things that we really worry about in patients with history of polymorphic VT or when you get an EKG and they have a QT interval that's very prolonged. So this person's QT interval, so QT interval is quite long. It should not be past really the halfway mark or just beyond the halfway mark between each R-to-R interval. So this is very prolonged. This is a patient that overdosed on tricyclic antidepressants. A really bad way to try to kill yourself. Anorexia, we all know anorexia, you get a lot of electrolyte abnormalities, especially with calcium and potassium. They get this kind of classic, very isoelectric, long ST segment followed by a prolonged QT. So this really prolonged QT interval. They often will have arrhythmias, torsade. You have to be careful because if you stick a tube down their throat and start feeding them, you can get refeeding syndrome, and their phosphorus and calcium can really go crazy, and they actually are more prone to arrhythmias during the early refeeding time. So you have to make sure you give them lots of magnesium before. The treatment of choice with this is magnesium intravenously. This is hypokalemia, hypomagnesemia. similar case where they're having lots and lots of ectopy, some ventricular ectopy. And you can see their QT interval is prolonged, especially the precordial leads. So this is torsade. This is the classic twisting of points, or torsade de point. It's, like I said, French, and I don't speak French, so, but you can see this kind of twisting. It looks like it's twisting on a rope, and it's pretty cool. I mean, the patient's about to die, but it's pretty cool when you see it. You just want to shock them. You want to shock them as soon as you can. And we also give them IV magnesium sulfate. Just to, the magnesium stabilizes the cardiac myocytes and treat the underlying issue. So whatever caused their QT prolongation, bradycardia. So if your heart rate goes too slow, all of a sudden you can develop torsade. Ventricular fibrillation. So VF is the most common cause. That's why you hear about sudden death from an arrhythmia is from ventricular fibrillation. So we all ultimately have ventricular fibrillation. That's just because the cells fibrillate when they're dying. It's often and almost exclusively occurs in structurally abnormal hearts, typically after an MI, so heart attack, myocardial infarction, or in the setting of an acute heart attack. So they're having a heart attack, they're having chest pain, their cells are lacking blood. Those cells that are, ischemic or on death's door, they start to fibrillate because calcium and potassium are leaking out of their cells, and they oftentimes will go into ventricular fibrillation. If it's because of an MI, we open up the blood vessel, we stick a little wire in, open it up with a balloon and put a stent in it. That restores blood flow. If it's in a patient that had a history of an MI and they come in and with sudden death, then we put an ICD in. Oftentimes we'll put antiarrhythmic drug therapy on board as well. That's amiodarone, sotalol, one of the class 3 antiarrhythmics. So this is VF. This is what's when people die. This is 6 seconds of VF. That's a long time to watch someone sit there, but I've seen it even longer than that. You want to shock them as quickly as possible. This is what an ICD looks like. So you have your generator, or what we call CAN. So the generator sits up in the left prepectoral area. When we put these in, we make a small incision just on the lateral border of the chest. Then this is a single chamber, so one wire. This is the electrode here. This is the coil. So this is a single coil. You can have dual coil, so a coil here and a coil here. This is active fixation, meaning that there's a little tiny wire that the screw comes out and sticks into the muscle and fixes itself into the right ventricular apex. Once we do that, we sew it all down, hook it up to the defibrillator, which is the battery. So computer, lithium battery. The wire fixes in, so you just plug it in, tighten the wrench, which is a screw, put it in the pocket, which is under the skin, above the muscle, under the skin, sew it up, put a little bandage on there, and they're good to go. These devices are basically idiots. They're just there to discern between, is there something fast that looks bad that I need to shock them? So typically 30 to 40 joules of energy required to defibrillate the heart. And you're between the vector of this coil and this CAN. So this is your defibrillation zone. So this is your right and left ventricles. So your defibrillating energy is through this area. So that's one way that we can put a defibrillator in. This is a subcutaneous ICD. So instead of putting it into the heart, we put this outside the heart. So this is just underneath the skin. So we put this along the border underneath the skin here. So this is the coil of the electrode. And this goes, we make a small incision over here and bury it beside your lat. So your muscle, latissimus dorsi. So you're just along the side of the rib, really kind of behind as deep as we can by the in the armpit. So it allows us to get the zone of defibrillation from here to here. So you're sandwiching between the ventricle. So that's why we need that can, but really far back. That's made by Boston Scientific currently. So I'm going to show you some arrhythmias on my other lovely laptop here, if this works. This is my cell phone and email. If you want to observe, even whatever, if you have questions, whatever you want to do, feel free to text or shoot me an email. I love to have students come into the lab and watch. I usually have a few every week, so you can come and watch and learn and ask all your questions. Or if you just have questions, shoot me an email. Okay, let's see how this works. Does anybody have questions while I'm trying to fiddle with electronic equipment?
I'm never sure if they're polite or asleep.
They might be asleep. There are a few that look like they're lost.
Somewhere in between. Okay.
So this is it's called Blaufuss. You can get the website at the top. It's blaufuss.org. When you go to the website, you just click on SVT, and then this little index will come up. Let me see if this works. And it's a crappy website, but give me a minute. I think I have to log in again. This may take a while. Okay. So what this hopefully will show is maybe I'll wait for it. Maybe it will slowly go. But what this is supposed to show is it's showing you the EKG with sinus activation. And it's actually a movie that's pretty cool once it plays. It's a Microsoft safe. Has Java and it's corrupt half the time. So okay, so this is AFib ablation. So when we do that, we're ablating around the pulmonary veins, which the veins are coming from the lungs. So this is oxygenated blood coming through the pulmonary veins into the left atrium. So the majority of focus from AFib is these are abnormal electrical cells coming from the ostium, the opening of these pulmonary veins. These are the only veins in the human body that carry oxygenated blood. And so some think it's a design flaw, but it's to help. The veins are very elastic, and so they, as humans have consumed more salt, have more high blood pressure, genetics, whatever, the veins really stretch more than they were designed to do. And so that stretching causes the muscle cells around them to become dysfunctional and start firing electrically. So those abnormal muscle cells start firing electrically into the left atrium, causing it to fibrillate. And that's what generates the impulses, these abnormal impulses. So what we do is we go in through both legs. So patients asleep, we have an anesthesiologist is making sure that they're asleep. And then I put in 4 IVs in the leg to the vein, run catheters up into the heart. We then poke 2 holes in the middle portion of the septum in the atrium. And then we go over into the left atrium. We map electrically what AFib looks like. And then we ablate, I cauterize or heat the tissue. I use ice and heat, but most commonly heat to actually get rid of those electrical foci. And typically it takes about 2 hours. Pull everything out, put these little closure devices called minks in the legs. Patient goes home 2 hours later. We used to do this by opening up the chest, taking the heart, lifting it out of the chest, cutting the atrium into 8 distinct pieces, and then sewing it back together. You can imagine how that worked. Patients didn't do so well. But now we can do everything minimally invasive with my fingers and arm, just to, it's like playing a video game. I'm seeing exactly what you're seeing on the screen, a heart in front of me, and all the catheters, when I move it, it moves on the screen. And so I'm just using my hands to make it go in the right direction. So it's cool. It's just like playing Nintendo back in the day. Except you're in the heart. So let me show a different one here.
So what's your top score?
I haven't had anyone die, so that's good. That's good.
It's a 1.
Yeah, it's a 1.
As opposed to a 0.
So this is atrial flutter. And so this is typical atrial flutter. So you can see it's going counterclockwise. That's the most common. So 80% counterclockwise, 20% clockwise of the typical flutters. And so what we do is we ablate so that's the ablation. So we ablate that little line. It's actually very short, and the flutter stops, and then we make sure you have bidirectional block. You paste from one side of the line, record from the other side of the line, and it should take a long time to go across that because you are now blocked. You've created a scar in that region. So now it has to go all the way around. So pretty simple physics. So let's see what else we got. I'm gonna try to do AV node reentry. If I can get it here. Okay. So this is the slow pathway. So you can see that the fast pathway is there, and the slow pathway is actually slightly lower than what they pictured. This is from Stanford, so they kind of suck at this stuff. But so it's just below, just actually in front of the coronary sinus, which is right there. So we ablate that little ridge. It's actually quick. These are quick procedures. Take about 45 minutes total. The only problem is that if you ablate the AV node, which knock on wood somewhere, I haven't done yet, but if you ablate the AV node, then you have to put a pacemaker in. And so you can imagine in like a 10-year-old heart, they're smaller, kind of close. So I use ice. So I freeze it, and it takes 4 minutes to freeze, only about a minute to ablate with RF, radio frequency energy. So if you freeze it, you just have to wait a little longer, it's not that long. So it's safer for those patients. Then I'll show you ABRT, which is an accessory pathway. This is WPW. Whoops. Let's go back. Okay. So this is the accessory pathway. So there's a pathway here. Conduction. So you ablate. You can see that they're pretty excited here. You start ablating, and the delta wave goes away. They're very satisfying cases. We like doing these. I just did the kid this week had a left-sided pathway, so over here. And they're usually take about an hour to do. If they're left-sided, you have to poke the hole. You have to take it's actually the longest needle ever made. It's really gnarly to get like that big needle, and your heart's like this big, and you're finding a little hole, and you're like, you stab it, and everything goes well. And I think there's one more. I think the atrial tachycardia. So this is an atrial tachycardia. It's a focal atrial tachycardia. This is the crista terminalis. This is the posterior septum. This is the two most common spots. So the focal lesion, we can put catheters up. We can find that little area and ablate somewhere. So that's the simulation of ablation. So we just put the ablation catheter wherever the earliest signal is. So it's kind of like we use a triangulation method. So you basically put a catheter in, and you can, just like geography, you're kind of honing in. Oh, it's late there, it's late here, it's early here. And you go over here and it's earlier and earlier, and you just find the closest spot, and then you ablate, it goes away. You feel like you did something good. So, any questions about all that? Yes.
On the ECG signals that you were showing us, there was like B1, B2, and B3.
Yes.
Are those like the same patient, different parts of the
Yeah.
heart?
So those are, when we talk about EKGs, they're vectors. So they're different leads. So each lead of the heart is coming from a different spot.
Oh,
So you
it's
put,
different.
yeah, B1 and B2 go in the fourth intercostal space. So here and here, and then B3, 4, 5, and 6. And so you're basically looking at the electrical forces from just different views.
Yeah.
So these are just simple electrode recordings from different measures.
Okay, and each one you can tell a different thing from.
Yeah, so if it's negative, if the force, the generic force, if you're just looking at the vector force, if it's all negative, then it's going away from that electrode. If it's all positive, then it's coming towards it. So you can kind of have to think 3D and conceptualize, okay, what does this look like? But there are apps that do this now, so you don't even have to worry about it. You just plug it all in and it tells you where it is coming from. But it's better if you understand anatomically, okay, the electrodes are here, it's negative here, so it's coming from over here and it's going over here. So I know that it's coming from the left side or it's coming from the apex and going up. So that's how we look at it. So, but most cardiologists, even general cardiologists, don't get that. They can't understand that. Electrophysiologists, we're the only ones that ever talk about it. So, yes.
For the case study that you mentioned, is there a reason why the ER starts with adenosine and then works their way through medication? Is there
I don't know how to put this nicely. ER doctors are trained kind of broad spectrum. So they say fast rhythm, let's do this type thing. And they have an algorithm for a fast rhythm. And so they see a young, healthy kid, they're like, oh, let's give the least invasive drug first and then go down the route, And so they give adenosine to everything, which is fine for me because that actually helps me to know what this is. But that's what they do. One of the ED doctors gave that to, not this patient, but another patient, and caused the patient to go into ventricular fibrillation. He doesn't do that anymore. So it's all by trial by error. He was actually a Cal Poly kid that he did it too, but the kid's fine. He lived. But the ER doctor, I think, had to change his underwear. It was pretty bad. I felt bad for him. But the big thing, if the patient's stable, like talking to you, and it looks like they have a blood pressure, then we say give drugs. Don't shock them, because nobody wants to get shocked while they're awake. If they look like crap, they're about to die, just shock them. It restores normal rhythm most of the time. So that's my general rule.
What are like the downsides to ablating? Like it sounds like it all is pretty easy and peachy, and we just go home and everything's fine. But like, what are the bad sides?
So there is not being able to ablate that area. There are complications that happen. So there's a case down. Reviewing the case for the other hospital, but tamponade, so you can burn and then burn a hole and then blood leaks out and fills the sac around it. So that there are things that happen. They're very, very uncommon, but they do happen.
So why would in those cases, why would a patient ever choose to be on medication over ablating? Like
most don't. Most will go to ablation. We don't even give options to some people. So if you have WPW, we don't put you on meds. We say you have to have an ablation. For AFib, it's a little trickier because AFib is you're never, even after an ablation, you're never cured from AFib because there are, whatever caused your AFib to begin with is still there. So do you have sleep apnea, hypertension, genetics, all that is still there that's causing your veins to dilate. So you get new stuff, 10 years down the road, you have AFib again. And so we just ablate you. We just keep ablating you. It's like the gift that keeps giving. Yeah. Yes.
What are the advantages of doing cryo over ablation?
So cryo is painless, so it doesn't hurt, and it's safe. So up to 2 minutes you can watch and then turn it off, and everything that you just did is reversed. It doesn't become permanent until after 2 minutes. And so 4 minutes is required to become permanent, but after up to about 2 minutes, you can just kind of safely watch and say, this looks safe. You can actually turn the dial down and get even deeper freeze to like -80, -120, and get a really good freeze if you feel very comfortable. But it's painless, so patients can be as awake as you want them to be. So, but it's also safe. It's very safe. But the problem with that is the efficacy. So it doesn't form as good a dense scar as RF, and so you can as the heat. So radio frequency, and radio frequency is immediate. So you get that kind of immediate satisfaction of knowing I did something, it worked, it's gone. Whereas ice, there's this like little transient period where the tissue can rewarm over the next day or two, and actually it can come back, where you don't have that satisfaction. So, but it's a good alternative. Yes. Both. So we use mostly irrigated, because with the irrigated you're cooling the surface that you're applying the heat to. It allows you to get more deep lesions, so you're getting the tissue a little deeper, and actually it's saving you from making kind of wide area lesions. It's actually keeping you really close to the actual part of the catheter. The newest technology over the last, since 2012-13, is force sensing. So irrigated force sensing catheters that are, you push here and it tells you how many grams of force you're pushing against the atrium. So that's very important for me to know, because before that I was just like, that feels good. Now I can say, oh, that's 14 grams. That's sufficient. You need 10 grams of force or more, but you don't want more than 50 grams, because if you're 50 grams, then you're going to poke a hole in something. So, and the hole is not good in the heart. So, any other questions, comments? Yes. So there are two going through phase 3 clinical trials in the United States. They're not commercially available. I did the ARC ablator, which is a 4-point, multi-point ablator for atrial fibrillation. It's like the semicircle ablator. But they're available in Europe. They're currently undergoing the FDA approval in the United States. So we'll see them. The cryo balloon, which is the balloon that's filled with liquid nitrogen and freezes the pulmonary veins, we use that as well. And so that's another technology that we can use you can isolate the entire vein fairly quickly within 4 minutes of freezing the vein. There's pluses and minuses to that. So, but Medtronic makes the cryo balloon. Does anybody need career advice? Or I deal with a lot of applicants, and I work for all the companies in their research and development, so I know them all. So anytime you need advice on that stuff, or which company to work for, or which one to intern with, I'll put in my 2 cents. So they're all, you can't go wrong with pretty much all of them. So I won't say too much. So, do you guys all have jobs coming up for internships, or is anybody thinking about going to med school? You should talk to me in a good way. No. I'd encourage you to go to medical school. It's still a good field, and with engineering background, it will make you very marketable. Anybody going to law school? Good. I just met another engineer that just is finished taking her bar. So just stay in school as long as you can. So does anybody have jobs? I know one has a job. Does anybody else have? I know some of you have stuff kind of lined up. Anybody have jobs they want to discuss? No, nothing. Well, I do encourage you to contact me. We can discuss lots of stuff. For the med school person, let me know. I do a lot of advising for AMSA and stuff. So if you need some help, and I write a pretty good letter recommendation too. So. But yeah. But if you need something, I'll be glad to look at it. And but yeah, feel free to text or email me, and I'll be glad to host you into the EP lab.
Anything else?
Hopefully you're still awake.
All right. Well, let's thank our guests. I really appreciate you coming, Chris.
Yeah, thank you.
I just find this stuff fascinating, and I promise you guys, all the terminology you're going to know by the end of this course, and all the arrhythmias. I'm going to show clips of your talk as we go back through some of these and analyze that. Good stuff.
Yeah.
So yeah, you're going to know this stuff backwards and forwards. We talked about the drugs. Hopefully you're going to know that.
Yeah, I love the drugs. So if you ever need like help understanding it, it's really, that's one of my favorite parts. I pimp a lot of students with this, so it's good. So, thank you guys.
Yeah, great.
Thank you.
Well, thank you. So just to remember, next week we have our quiz on Thursday. I'm going to post a bunch of review questions over the weekend, so keep your eye out for those. And see you back here on Tuesday.
That's what you said.
Yeah.
Okay, I'm just curious about tomorrow. Do you want us to? Oh, I'm gonna.
Oh yeah.
Do you want us to run the lab by ourselves?